بسم الله الرحمن الرحيم. النهارده هنتكلم عن السوفت ساركوما. السوفت ساركوما is despite its rare tumor, you should know it. You should know everything about soft sarcoma. These are peculiar group of tumors. As you can see, they are tumors that affect soft tissue. What's meant by soft tissue? Soft tissue means every component of the tissue. If you take a cut section in your hand or leg or something, from fat, fibrous tissue, muscle, nerve, blood vessel, and even bone. These are soft tissue. These tumors are large. They are liable for recurrence if not surgically excised adequately. The definition of sarcoma: they are malignant tumors that arise from skeletal and extraskeletal connective tissue and mesenchymal cells, including adipose tissue, bone, cartilage, smooth muscle, skeletal muscle. As I say, these are the components of what the term soft tissue, and they are usually referred to as extremity soft sarcoma. They are very common in extremities. They are rare and, as I said, an unusual plans. They constitute about 1% of adult human cancers, 15% of pediatric malignancies. They are commonly occurring in extremities, around 50%. That's why we call extremity soft sarcoma. They are also common in the abdominal cavity, retroperitoneum, trunk, thoracic region, head and neck. Where do they arise? They may arise from fat, adipose tissue, from fibrous tissue, fibrohistiocyte or fibroblast, from muscle, either smooth or skeletal, from blood vessels, vascular tumors, from the joint, synovial, from skin, appendages, melanoma or something, and unknown sites. An important slide, the next slide, they may retain sarcoma to its origin. These are the pathologic types of sarcoma. They include sarcomas of fibrous tissue like malignant fibrocytoma, the first. Actually, malignant fibrocystoma is common, as we'll see later. You know the other term of malignant fibrosarcoma, it's called undifferentiated sarcoma. Yeah, that reflects an aggressive biology. The term sarcoma already means an aggressive tumor that spreads by blood. What about undifferentiated sarcoma? It refers to a very aggressive tumor that may metastasize rapidly. Low-grade fibromyxosarcoma, the hematofibrosarcoma protuberans, desmoid tumor is some sort of fibromatosis. We have sarcomas of peripheral nervous tissue like malignant peripheral sheath tumors, malignant schwannoma neurofibroma. We have sarcomas of skeletal muscle like leiomyosarcoma that may arise from gastrointestinal tract, genitourinary tract, skin, blood vessels, and so on. We have also sarcoma from the fat, like liposarcomas. It's very common, liposarcomas, as we'll see later. Sarcomas may arise from blood vessel and lymph vessels. They are either angiosarcoma, epithelioid hemangioendothelioma, hemangioepithelioma, and Kaposi sarcoma. Plus sarcomas of skeletal muscle like embryonal rhabdomyosarcoma, alveolar rhabdomyosarcoma, pleomorphic rhabdomyosarcoma. Sarcomas may arise from unknown tissues like synovial sarcoma, monoplastic sarcoma biphasic, alveolar soft tissue sarcoma, and epithelial sarcoma. Well, can I know soft tissue sarcoma by histology? Can I know the type of sarcoma by knowing its site? Yes. If the sarcoma is in the extremity, it is usually either liposarcoma or malignant fibrocystoma. I have discussed them before. If it is located in the retroperitoneum, it is either liposarcoma and leiomyosarcoma. They're very common. Sarcomas may occur in the gut, viscous, the gastrointestinal tract. They are all summarized in a term that's called GAST. Previously, we called gastric leiomyoma, gastric leiomyosarcoma, intestinal leiomyoma. All these tumors that arise from a non-mucosal part of the gut is called gastrointestinal stromal tumors. And this is the location and the type. Can I know the type of sarcoma by knowing the age of my patient? Yes, I have known already the type by the site, but I can know the type by the age. In childhood, as we said, this sarcoma is more common, and the commonest type is embryonal rhabdomyosarcoma. Teenage young adult, like 15 up to 35 years, synovial sarcoma is more common. An even distribution of liposarcoma and malignant fibrosarcoma in older population. As we said, the same two are very common in extremities, and soft sarcomas in general are very common in extremities. Okay. Okay. So the risk factors for sarcoma include genetic predisposition, like neurofibromatosis from the Klinghausen disease, Leframine syndrome, retinoblastoma, Gardner syndrome. Risk factors for soft sarcoma also include radiation exposure, parasitic infection, trauma, and chemical. Diagnosis of soft sarcoma. They usually present with a painless mass. However, pain is noted at presentation in up to 33% of cases. Delay in diagnosis is common. That's why we should know everything about sarcoma. Tumors, cancers are quite treatable when they are diagnosed and discovered early, with the proper guides for the physician to diagnose it. We have a golden rule in diagnosing MS. This rule is triple assessment. Yes, there is nothing called, I see a patient with a lump and I'm going to say, hey, this lump needs excision. No. This lump needs nothing. Please follow me up. Both around. You should should listen to the history of the patient, examine her carefully, both general and local, then mention your provisional and clinical diagnosis. This is the first assessment. They are triple. The second assessment is the proper radiology for this case. And the third assessment is biopsy. Misdiagnosing cases of sarcoma is very common, with the commonest diagnosis, even at radiology, is hematoma or pulled muscles. Yes, this is responsible for delaying diagnosis of these cases, and most of cases present in a very advanced late stage. Okay. Diagnosis should include assessment of the size of the mass and relationship to the neurovascular structure, and then you should biopsy of the mass. Let us memorize this dictum. Any soft tissue mass that is symptomatic or enlarging, larger than 5 centimeters, or any new mass that persists beyond 4 weeks should be sampled. Again, if we memorize this rule, we will never misdiagnose a case of sarcoma. The mass is symptomatic, enlarging, more than 5 centimeters, a new mass developed beyond it, or it persists 4 weeks and more, should be sampled. If we know this, we will not see a case of misdiagnosed sarcoma. Diagnosis is done by, yes, through biopsy, core biopsy. We have rules in dealing with sarcoma. Sarcoma is one of the peculiar tumors that spread along fascial planes. What? Yes, fascial planes. We know sarcomas can spread by blood, by lymphatic tumors. What about these fascial planes? This makes it difficult. Please do not open a wrong plane, or else sarcoma will develop in it. The entire tract of the biopsy should be excised. The incision should be centered over the mass and at most superficial location. Meticulous hemostasis should be done to prevent hematoma or dissemination by hematoma. Okay, this is an MRI of a lesion, and we can see this is a Truca biopsy, and this is the track of the biopsy. Yes, you can see it. The needle entering in the mass, taking its biopsy. It's called image-guided biopsy. A diagnosis is done by MRI, which is the preferred method. It enhances the contrast between the tumor and adjacent structures. It provides excellent three-dimensional definition of the fascial planes and adequately relate it to the surrounding structure. As you can see, this is a tumor. It is surrounded by muscles, and it is nearly located to the bone. Staging T1 and 2 and 3, however, we care about that tumors at presentation are usually large, starting from 8 centimeters and more. Yet, we should know this. Whatever the linear treatment, the outcome of sarcoma is bad and worse in large tumors if the tumor is deep, if it's high grade or intralesional excision is performed, visceral sarcomas like retroperitoneal versus limb, metastatic at presentation. If the patient has a large tumor, deep, managed by intralesional excision and high grade, whatever I do, unfortunately, the behavior of this tumor is progressive. What are the management options available for case of sarcoma? Number one, surgery. Sarcomas are radio-resistant and chemo-resistant. The factors that affect surgery include location, size, depth of invasion, involvement of nearby structures, necessity for skin grafting or autogenous tissue reconstruction, and patient performance status. The golden rule is operative resection with negative surgical margin is the most effective method of treatment of most adults with soft tissue sarcoma. Yes, resection with negative surgical margins is very important. You can divide the types of surgery by the golden standard of surgical section is what's called wide local excision. Wide local excision means I can excise a mass with adequate piece of tissue surrounding it that range from 3 to 5 centimeters. It's called wide local excision, excising the mass with septum margin. However, this could not be obtained in every case. You may be confronted by a wound, by a blood vessel, by important nerve that must be excised to obtain this margin. So you can excise it with a very minimum septum margin. It's called margin resection. Margin resection can be accepted if it is followed by radiotherapy or if it follows the adjuvant treatment protocol like I will discuss. However, to excise this mass with septum margin, you may be confronted by excising the whole compartment, either like medial compartment or a posterior compartment of the thigh from origin to insertion. It's called compartmental excision. If this is going to leave a useless limb, amputation may be the solution. The bulking means excising as part of the tumor as I can, and this is obsolete. This should not be done in sarcomas. And lastly, surgery combined with radiotherapy, as I said, if my margin is not quite enough. What about marginal resection? The resection margin, as I say, it's just the capsule around the tumor that presents a compressed normal tissue. Usually, this margin is invaded by tumor cell. However, combining this with radiotherapy may minimize the local recurrence. Wide local excision is a secondary standard. If I can excise the tumor with wide margin, at least, as I say, from 2 to 5 centimeters. Yes, it's important for that my margin should encompass and include the previous biopsy scar. Septum margin can be smaller when the tumor is delineated by fascia, like it acts as a barrier. Periosteum, adventitium, perineurium act as a barrier for spread to bone, blood vessels, and nerves. Compartmental excision is reserved for tumors occupying a compartment. I'm going to resect the whole compartment from origin to insertion. A functional deficit can be anticipated, of course. Amputation. Now, the rule of amputation management soft tissue sarcoma account no more than less of 5% of all cases. The resection usually requires a disarticulation of the joint proximal to the embedded capsule. For example, if I have sarcomas in the hand, you can cut above the wrist. It's called blue elbow amputation. Okay. Is there a place for sarcoma right now? Yes, there is still a place, but in very limited number of cases. Indications of amputation include inadequate limb function after wide local or compartmental excision, large size or multi-compartmental involvement, encasement of bone or neurovascular structure without potential for reconstruction. Resection of adjacent structure. Yeah, if the completion of your wide local excision entail, or you must remove an important blood vessel and remove it if there is a possibility for reconstruction for the safety of the patient and his cure from sarcoma. Okay. A well-planned repair of anatomical defect following appropriate surgical section minimize the morbidity associated with the extensive loss of soft tissue and facilitate prompt functional and physical rehabilitation of the patient. Am I going to do lymphadenectomy? As we know, all cancer should be dealt by what's called radical surgery, and this radical surgery includes removing lymph nodes. In sarcomas, shall I remove the lymph nodes? Usually no. No. Only 2 to 3% of patients with sarcoma may have lymph node metastasis, especially with cerebral sarcoma, malignant fibrosarcoma, epithelial sarcoma, and vascular sarcoma. Surgical management metastatic disease for isolated pulmonary metastasis, there is a rumor for lung bilateral lung section. If you have a sarcoma, the common site of metastasis is the lung. If there is a solitary metastasis, yeah, you can remove it by isolated resection, and actual reports saying there is a good survival advantage. Radiotherapy in combination with surgery, it gives a better outcome because it's local recurrence. But what about neoadjuvant? The term neoadjuvant means preoperative. I can do for my patient before surgery a radiotherapy or a chemotherapy. Indication include larger tumors than 5 centimeters, high grade and deep. They minimize visible injury in sarcoma, however, they are difficult for radiologic assessment of the mass. Post of radiotherapy, of course, as I say, it decreases. What about chemotherapy? Usually the rule is soft tissue sarcomas are radioresistant. Chemotherapy may be adjuvant if it is given after surgery, or neoadjuvant. For adjuvant treatment, the survival advantage is little. However, for an adjuvant treatment, you know, the most aggressive type of soft tissue sarcoma is killed instantly when you pour chemotherapy in it in vitro. However, the dose that kills this sarcoma is about 7 to 10 folds the dose that can kill the host. Yes, this is a problem. The problem is concerned about the cytotoxicity and side effects of chemotherapy. Yes, unfortunately, your host is going to be killed before his tumor is killed. What was tempting is soft tissue sarcoma. They more commonly occur in extremity. So, can I isolate an extremity and give him larger dose of chemotherapy without minimizing the chance of systemic absorption? This is called neoadjuvant regional chemotherapy, and actually you can do this. Neoadjuvant regional chemotherapy is tempting for this. It's called isolated limb perfusion. You can isolate an extremity and put high dose chemotherapy trying to kill the tumor, and it actually works. It gives an overall advantage. Retroperitoneal sarcoma, complete surgical resection is most effective line of treatment. They may be huge sarcomas, and the retroperitoneal may be huge enough to reach this mass, and they can even destruct a bone like this. You can see the half of the ileum as lost. This is a golden picture of surgery of soft tissue sarcoma. You can see the mass is whole wrapped. You don't see the mass, but you see normal tissue around it. Yes, this is the mass enclosed in a muscle wrap, and this is an important structure like sciatic nerve, femur, and the important blood nerve vessels are left untouched. This is an example of neoadjuvant chemotherapy. This is a case presented with sarcoma planned for amputation. However, after giving neoadjuvant chemotherapy, and this is the microscopic picture of it, heavily cellular mass. After neoadjuvant chemotherapy, the mass is changed into wide areas of necrosis and cystic degeneration, and you can see all cells are gone. Yes, it is a bag full of empty cells, dead cells. So you can just remove them. This is when marginal resection is going to be effective. Adjuvant chemotherapy, regional chemotherapy. It's a case of preoperative patient, immediate postoperative, and 1 year, and these patients were followed for 7 years after this. This is a huge retroperitoneal sarcoma. It can be quite large. Yes, it can be quite large sarcomas, unfortunately. And this is a case of huge retroperitoneal sarcoma, big size. GAST, as I say, is the gastrointestinal tumors. There are separate types of sarcoma defined by overexpression of KIT. Complete resection without local regional lymphadenectomy, very resistant to additional chemotherapy. Glevic, called imitanib, which is a target therapy, was one of the first therapies to be effective, like this condition, GERD. And this is another example of GAST. As you can see, it's large mass. And a specimen of extremity sarcoma is removed. Sarcoma in the breast accounting no more than 1% of all breast neoplasma, extremely negative margin. There is no clear rule for radiotherapy. Sarcoma after mastectomy, it's actually angiosarcoma. Vascular tumors like angiosarcoma, hemangiopericytoma, mangioepithelioma, the key points and hepatic high risk of bleeding during excision. Lastly, in this lecture, we have known soft tissue sarcoma. It's a red neoplasm, but it's characterized by it has the ability to spread by facial planes. Misdiagnosis is very common. You should know the indications of biopsy. MRI is the preferred radiologic tool. You should biopsy it by TrueCut. It is a surgical problem. There is a rule for neoadjuvant regional chemotherapy. And lastly, thank you.